have a second go at. And so now she has more limited options for managing that contralateral breast cancer. She's also had to have an additional appointment. We find that with these patients, sometimes that will clash with treatment. In many places around the country, it will be at a completely different hospital or be in a different city. And it may occur on a day when she has significant chemotoxicity and doesn't feel like turning up to hospital. So this means that you can get further delays or DNAs from the appointments. And of course, if we had known up front that she was a BRCA carrier, that may have had an implication on the chemotherapy that she received or things such as trial options. So when we look at this kind of program, you can see that genetic testing was originally designed to limit testing because it was initially something that was very resource intensive, cost a huge amount of money, and this came up at a time when there were treatment implications for the patient in front of you. And most of the reason for undertaking this testing was to inform the family as to whether or not they may have an increased risk in future. Because it was so resource intensive, criteria were set to select the high-risk individuals, but that means that we were missing many of the patients who would have a mutation and benefit from knowing about this. And this is particularly true if the mutation has been inherited through the paternal line, because of course with most of these cancers, they are female-dominant cancers. So if this has come through, for example, a grandfather and a father, you won't have that family history to identify that there may be a gene in the family. Other thing is that in general, people tend to think about BRCA when they find a triple-negative breast cancer, because they understand that there is that link between triple-negative breast cancer and BRCA1. But many of the patients with estrogen receptor-positive breast cancer historically have been undertested or not tested because there wasn't recognition of the fact that they may well still have a mutation. What we have now, however, is a focus moving towards the impact on treatment for the patient rather than just for the cancer prevention in the family. And it's also important to note that breast cancer has a really high survival rate. So the vast majority of patients who have a breast cancer will be successfully treated and will go on to live long lives. But the problem is if that individual still has a 50% risk of a second breast cancer and a 40 to 60% risk of an ovarian cancer, it's helpful to know about that because it's devastating when they turn up with a second or third cancer that you could have potentially prevented.